Good afternoon. Thank you, Mr. Chairman. Thank you very much for this kind invitation. I'm very happy to be here in India. This is the first time for me, and I'm really enjoying it. During the next 25 minutes, I'm going to talk about extracorporeal blood purification techniques, and more specifically on high flux therapies and adsorption surfaces. These are my conflicts of interest. And this is the city where I come from. I come from Lyon. This is the second city in France. And this is a city famous for the way of living. It's very cool to live there. I invite you all, if you come, just shoot me an email and I will welcome you. You have mountains, you have the French Riviera, which is not too far, but above all, you have very good food and very good bottles of wine. And also, these two guys are quite famous because these two brothers are called the Lumière brothers. They were living in Lyon and they invented the cinema. So the cinema was not invented in Hollywood in the United States, but was invented in Lyon some time ago. So now let's talk about sepsis for a few minutes. So as it was said before, there is a new definition of sepsis, was released last year. And you know now sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So I think this is extremely important because it brings immunology as part of the sepsis definition. So now if you want to do intensive care, what I tell to my fellows is that you need to study a lot immunology because immunology is now very present in the ICU. We need to know a lot about immunology. This is based on data from, a lot of data from Richard Oxiris from St. Louis in the United States. And he reported that when there is an infection, there is actually a double inflammatory response occurring together with a pro-inflammatory side and an anti-inflammatory side. And during the first days, the net balance is more on the pro-inflammatory side. And then after a few days here, you can see that the net balance is on the anti-inflammatory side. And this immunosuppression state, immunoparalysis, is very deleterious for the patient because the patient at this stage cannot fight against secondary infections, cannot fight against nosocomial infections, viral reactivations such as CMV, HSV. And that's why a lot of patients die of sepsis at this time. When we receive a patient for septic shock in the ICU, the patient usually doesn't die here. When he dies, unfortunately, he dies later on after a few days, sometimes at 7 days, 10 days, because of secondary infections, because he cannot fight against this new infection. And this is due to the release of all these mediators, all these inflammatory mediators. So how to go back to immunohomeostasis? You can do it in two ways of research. The first one is drugs. GM-CSF, interferon gamma, IL-7 are at this time under investigation, but also extracorporeal blood purification techniques, you can see here, can bring you from the hyperimmune phase at the very beginning back to immunohomeostasis. And also at the immunoparalysis state, you can try some specific blood purification techniques to go back to immunohomeostasis. So indeed, when you're an intensivist and you are in the ICU, you can initiate an extracorporeal technique for two reasons. The first one, of course, it's renal support for acute kidney injury. That's as a standard. And then also for sepsis, you can decide to initiate a blood purification therapy to modulate this inflammatory response. You know that 50% of acute kidney injuries are related to sepsis. So sometimes when you have sepsis-induced acute kidney injury, it could be beneficial, it could be interesting to get a therapy which does the two things at the same time, renal support and blood purification. So how to remove molecules from the blood? You can do it, so you know this very well, by diffusion, by convection, and also by adsorption. What is adsorption? Adsorption is a mechanism by which the molecule, which could be a very large molecule, is going to be stuck on the sorbent thanks to three kinds of interactions: hydrophobic interactions, van der Waals forces, and ionic interactions. So do we know how all these blood purification techniques work, actually, in terms of pathophysiology? We don't know. We don't know how these techniques work. Should the target be the endotoxin, which is known to be the trigger of the inflammatory response? Should the cytokines, the inflammatory mediators after the endotoxins, should the cytokines be the trigger? This is a Claudio Ronco hypothesis, the peak concentration hypothesis. Or should we expect an indirect or direct action on the leukocyte itself? Because we can also, we have now new devices with whom the molecules can interact with the sorbent, the leukocyte can interact with the sorbent, leading to a modification of the leukocyte surface markers. And also now we have devices which are able to remove the leukocytes itself from the blood. Not only the endotoxin, not only the cytokines, but the leukocyte itself can be removed from the blood by adsorption. Should we remove activated leukocytes? So this is the proof. You have here some electronic microscopy and immunofluorescence pictures showing that in some devices, this is the divinyl benzene beads from the CytoSorb technology. You can see that some leukocytes, actually the neutrophils and the monocytes, not so much the lymphocytes, but the activated leukocytes can be adsorbed on the beads and then removed from the blood circulation. So is it good to remove leukocytes from the blood when you have sepsis? Actually, I don't know at this time, but this is not so crazy because if you look at other diseases, other inflammatory diseases, such as ulcerative colitis, this is a treatment already proposed and which is done a lot, I think, in Japan. So now, let me show you the list of all the available extracorporeal blood purification techniques in 2017. So you have high-volume hemofiltration, cascade hemofiltration, plasma exchanges, coupled plasma filtration adsorption, hemoperfusion, and the new membranes, high adsorptive hemofilters, and high cutoff membranes. So I'm not going to talk about all of them because I don't have enough time, and other speakers have already or will talk more specifically on some of the techniques. But I'm going to mention some words about high-volume hemofiltration. So high-volume hemofiltration is the oldest technique, very promising in the 1990s in animal models and in the early years of 2000, with a lot of interesting, promising data from observational studies. But the Edouard study, which has been released last year in 2016, which is a randomized controlled trial, a multi-center randomized controlled trial in Europe, randomizing high-volume hemofiltration with 70 ml per kilo per hour of ultrafiltration versus 35 ml per kilo per hour in patients with septic shock. And actually, the primary outcome was 90-day survival, and there was actually absolutely no difference. This study, I believe, killed this technique, but not only because of the result, it's also because a lot of drawbacks are known to be observed with high-volume hemofiltration, with the release of the small molecules in a very high amount of liquid. Also the fact that it was said by, I think, Dr. Liu before, that your nurse is not going to be very happy if you run high-volume hemofiltration in your unit, and it's also very expensive. And also because of the release of all the other techniques. So I think this technique is not so much used anymore at least in Europe and in the United States. So now I'm going to talk a little bit about this interesting technique called coupled plasma filtration adsorption. In this circuit, the blood goes first in a plasma filter here, and then the plasma goes through this cartridge from which is divinyl benzene styrenic resins. And then on this resin, the plasma, the cytokines are adsorbed very efficiently. So here you have the plasma cleaned from the cytokines. And then the plasma goes back to the circulation. And then in this part of the circuit, you can run standard hemofiltration for renal support, for example. So actually this is called a hybrid technique. Very interesting because you can do two things at the same time. You can do blood purification in the first part of the circuit and renal support in the second part of the circuit. So actually this is kind of interesting for sepsis-induced acute kidney injury, I believe. So why is it interesting to run the plasma on the cartridge and not the blood, like for other hemoperfusion techniques? If you run the plasma on the cartridge, you don't have any clotting problems. So you can run the plasma in a very slow way with a very low plasma flow rate here. And if you decrease the plasma flow rate, then you increase the time of contact between the molecules and the sorbent. So you optimize your adsorption when you run the plasma on the cartridge. That's why I believe this is interesting. When you look at the literature in terms of data with coupled plasma filtration adsorption, there are about 20 to 30 articles. A meta-analysis was reported last year, in 2015, showing an interesting signal in terms of survival. But the most important study is the multi-center randomized controlled trial called the COMPACT-1 study, which was published in 2014. In this study, the investigators compared standard treatment for septic shock versus standard treatment plus 5 days of CPFA. They wanted to recruit more than 300 patients in 18 centers in Italy, but they stopped after 200 patients on the grounds of futility because there was absolutely no signal in terms of survival. It was exactly the same, so it was a negative study. However, the investigators ran a sub-analysis, and they found that when the patients received a high dose of CPFA, then the survival was better. You have here the dose of CPFA, and here this is the mortality. So when the patient received a high dose of CPFA, then the mortality was decreased, and that was statistically significant. So based on this sub-analysis, they decided to start another COMPACT study. This is called the COMPACT-2 study in Italy, comparing high dose of CPFA versus standard treatments. And then we will have to wait for several years before getting the final answer for CPFA. So let's talk a little bit about hemoperfusion, which is a very famous technique in Japan. I think all septic shock patients in Japan receive polymyxin B hemoperfusion. This technique was not so famous in Europe and in the United States until the release of this publication in JAMA from Claudio Ronco's group. This is a positive study run in 10 Italian ICUs from 2004 to 2007, and they compared conventional treatment for septic shock versus commercial treatment plus 2 sessions of polymyxin B hemoperfusion. And that was, again, a positive study with a lot of improvement in terms of hemodynamics, in terms of respiratory parameters, and in terms of SOFA score. They even found a statistically significant effect, positive effect, on survival. The patients who received polymyxin B hemoperfusion survived more in that study. But it was still a controversial study because not so many patients, only 64 patients. And so we were waiting for the release of the 2 large multi-center randomized control trials with polymyxin B. The first one was released last year. It's a study from Didier Payen in France. It's called the Abdomix study, looking at patients with septic shock due to peritonitis. And that study was very disappointing because it was totally negative. Even there was a trend of higher mortality in the group with polymyxin B hemoperfusion. So very surprising results. And they were waiting for the Euphrates study. This is the American study, basically with the same kind of patients. And the paper has not been released yet, but it has been presented in several international meetings. So I can tell you that this is also a negative study. However, again, in this study, they looked at the subgroup analysis with a subgroup of patients. And as you can see here, in the patients with a SOFA score of more than 9 and an endotoxin levels between 0.6 and 0.9, they found a 10% decrease in the 28-day mortality. So interestingly, again, in a subgroup of patients, there was a positive effect. So it's difficult to conclude for polymyxin B hemoperfusion. Regarding hemoperfusion, there's not only polymyxin B hemoperfusion, which targets, again, endotoxin. Then you can also find in the industry the other devices, the divinylbenzene beads proposed by Cytosorbs. And this technology is able to non-selectively remove cytokines. You see here TNF, IL-1 beta, IL-6, IL-10 from the blood. So this is also a new technology proposed to remove cytokines from the blood. Human studies are underway right now with this device. I'm going to say a few words about Oxiris, although it was already mentioned. So Oxiris targets the trigger of the inflammatory response, the endotoxin. It's an IN69-based membrane filter based with polyacrylonitrile, and in which the company has added a positive charge at the surface of the membrane in order to remove negatively charged molecules by adsorption, which are heparin, so it's a pre-heparinized membrane, but also endotoxins. So endotoxins are removed at the surface of the filter by adsorption. So not a lot of data, not a lot of human data with Oxiris, just animal data. This is pigs in septic shock. And these pigs they received a 6-hour hemofiltration session. One group of pigs received Oxiris filter, and the other one received a standard membrane. And as you can see here, this is the Oxiris data. Hemodynamics was improved in the pigs with Oxiris, and interestingly, the endotoxin levels was 10 times less important in the pigs who received Oxiris. So the capacity of the membrane to absorb endotoxins were demonstrated in this work. High cutoff membranes, what is it? So also the technological improvement allows now the industry to propose membranes with an increase of the diameter of the pores, with the idea of, with the goal of to remove a wider range of inflammatory mediators. The main problem with these membranes is that sometimes you can find in the literature some clinical studies where albumin was removed and sometimes in a very high level, 30 grams per 4 hours. This is huge. So these membranes are not used in daily clinical practice because of this. So if you want to test or to try high cutoff membranes, probably you need to use them in a diffusive mode, like in continuous hemodialysis and not continuous hemofiltration, because then you're going to limit the loss of albumin. But also you need to use membranes with a reasonable cutoff. You can find in the literature and in the markets some membranes with a cutoff of 100 kilodalton, 150 kilodalton. Of course, this is way too much. But if you use some high cutoff membranes with a cutoff of between 40 to 60 kilodalton, this is called the super high flux membranes, then maybe you are fine. And we actually tested these kind of membranes, and we found that we don't lose a lot of albumin. So maybe to use high cutoff membrane in a safe way would be to use them in a diffusive mode and with some membranes with a reasonable cutoff. So now when I am in international meetings, sometimes I have to face this question now quite a lot. A lot of physicians, they always tell me, okay, in the past, there was a lot of data showing interesting results in observational studies in animals,
in preclinical works. But when we look at the randomized control trials, the large randomized control trial, these studies are negative. So some people, they say, okay, we should stop looking at these extracorporeal techniques because this is enough. So now, this is very important because I believe they are totally wrong. This is, of course, no, for at least 6 reasons. First one is, this is wrong to say that all the results in humans are negative. This is positive study, published in CCM 2013, John Kellum's group, meta-analysis looking at blood perfusion techniques, a lot of polymyxin B hemoperfusion articles here, positive result. I've shown you this data from Claudio Rocco, published in JAMA 2009, positive study. In the compact 1 study, which is, this is true negative, the sub-analysis was interestingly very positive when there was a high amount of CPFA done to the patient. This is positive data. This meta-analysis was also positive. And this sub-analysis with the polymyxin B hemoperfusion is also positive. So all the people who tell you that all the data are negative are wrong. They are you look at the literature, you can find some positive studies. These 3 papers, the Edouard study, the Abdomic study, and the Compact 1 study, are the 3 negative, large, multi-center randomized control trials. But they are full of limits, full of limits. In 2 of them, they wanted to enroll, like, for example, 300 or 400 patients. They enrolled 100 and 200. They did not reach the number of patients they wanted. So how can they conclude, and how can we all trust this data? And they are also full over the limits I don't have time to display. So be careful with these 3 papers, and maybe we should not draw too quick conclusions, I would say. 3, let's ask the experts from the Surviving Sepsis campaign. For the first time in history, there is a paragraph in the Surviving Sepsis campaign guidelines about blood purification techniques. And they don't know what to say. Our confidence in the evidence is so low in favor or against the blood purification techniques. So actually they cannot conclude. They are like us. When you look carefully at the literature, you have conflicting data. You cannot draw any conclusion, and this is what the expert of the Surviving Sepsis campaign tell us. So I believe we should continue to do research. 4. So we've seen some large randomized control trials with high volume hemofiltration, with CPFA, but did you see any large multicenter trial with cascade, plasma changes? I mean large, several hundred patients. Hemoperfusion with cytosorbs, with Oxiris, with high cutoff membranes? I did not. I haven't seen any large multicenter randomized control trials. Why should we stop research in this field? I think this is very important, and which might explain why you can find some negative studies. When you test a molecule, a drug, an intervention, anything, and if you take a too large population, then you can get 3 subgroups of patients. The first one, the intervention is deleterious. The second one, the intervention is neutral. And the last one, the intervention is positive. But the problem is when you look at all the patients together, then the positive effect can be hidden by the whole population. And that's why you can get you get so many negative studies, I think, in medicine in general. And this is the future. The future is quite amazing to look at what the industry was proposing 10 years ago and what the industry proposed now. This goes so fast. Look at this. This is completely crazy. This is from Harvard. Very serious guys. $10 million US project. This is very complicated. I don't have time, 45 seconds left, so I will not go through details. But basically, this extracorporeal blood purification technique removes not cytokines, endotoxins, leukocytes. They remove bacteria themselves. You can remove the bacteria with this device. On the other side, on the United States, in San Diego University, this device is able to decrease the virus load. You can remove. So actually, what should we remove? Now we have technology to remove everything: endotoxin, cytokines, leukocytes, bacteria, viruses. So the industry is now very powerful. And then I would like to conclude with this. So please, can I keep my conclusion? Thank you so much. That would be very nice of you. So sepsis is frequent, poor prognosis, is very expensive. Very importantly, since last year, now immunology is part of the sepsis definition. The patients who die of sepsis, they die of immunosuppression. All these extracorporeal blood filtration techniques, we should say that they are under investigation. The multicenter randomized control trial, they were negative, 3 of them, but were they all well designed? I'm not so sure. What we should keep in mind is we have many unanswered questions. Which patients, which subgroup of patients? Because I showed you that, in some group of patients, you can find positive results. Which timing, which technique, what to remove? Cytokines, endotoxin, leukocytes, bacteria, viruses. So I hope I convinced you that research in this field should continue. Thank you very much for your attention.
Thank you, Dr. Rimmele. It's over to the chairpersons for their quick comments for the next 2.5 minutes. Over to you. Thank you.
The compact one study, they have seen the mortality on 28 and 90 days, and they have used the plasma filtration of 200 ml per kg per day. What is the problem in the mortality, see the 28 and 90 days in compact one study, which was corrected in the Rompa trial?
Could you repeat which study? The
compact one.
Oh, compact one study, yes. So the compact one study was the negative study with CPFA. The main problem with CPFA was the protocol breaches. A lot of patients included in that study did not reach the protocol. 50% of them because of clotting problems. So it was very difficult for the investigators to give a lot of CPFA, a significant dose of CPFA. And actually, only a few patients were given a high amount of CPFA. And very interestingly, these are the patients who survived the best. That's why they start this compact 2 study with a high dose of CPFA versus standard treatment. And you know what? They are going to use citrate in that study to avoid clotting problems and then to allow the patients to receive a high dose of CPFA.
Okay. We just time for one last comment, if there's any from chair.
Anybody in the audience has a question rather than we asking? Otherwise, I'll ask. Anybody? I just have one question, practical. I mean, these patients are hemodynamically very unstable. So how do they tolerate this procedure and the cost of it? The blood purification, the adsorption, Hemo perfusion.
The cost of these techniques? Yeah, the cost, of course, is one issue. Most of them are quite expensive. High volume hemofiltration was quite expensive, as we said before. CPFA is quite expensive as well. Hemo perfusion, very expensive, several thousands of euros the station. So you are right that it's difficult, and that's why the international guidelines do not recommend to use all these techniques in daily clinical practice. This is because that would cost a lot of money, and the effect in the literature is not demonstrated so far. So I think when you use all these techniques, it should be, I think, part of some studies, some clinical work in order to provide more data in the literature.
Okay, sorry for the interruption, Madam Chairman. That's all the time that we have for the discussion.
Thank
We'd
you.
like to thank the chairperson and the speakers and request them to please join us for a presentation ceremony.